optic nerve head edema 3 months back with blast cells detected on bone marrow and CSF analysis, and was on reinduction with venetoclax, carfilzomib, intrathecal chemotherapy, and followed by cranial radiotherapy. On examination, the right eye had a best corrected visual acuity of 6/9 parts and an intraocular pressure of 36 mm of mercury. And he also had a 2 mm of pseudohypopyon and multiple undulations on the iris. Left eye also had 1+ cells in the AC. Fundus examination showed right eye grade 1 vitreous haze with a parafoveal scar, and UBM ultrasound biomicroscopy showed hyperechogenicity of the iris and thickening with variable depth of the anterior chamber. Left eye fundus was within normal limits. So considering a DD of intraocular metastasis, we went ahead with an AC tap where the histopathology showed lymphoid cells with scanty cytoplasm and cleaved nuclei, and immunohistochemistry was positive for CD3, CD10, leukocyte common antigen, and terminal deoxynucleotide transferase. The child was started on topical steroids, cycloplegics, and anti-glaucoma medication, and the oncologist started cladribine, cytarabine, idarubicin, and venetoclax. Within a month, the pseudohypopyon resolved with normal IOP, but both eyes showed persistent AC cells. The next month, again, the right eye vision dropped to hand movement with a 6 mm pseudohypopyon covering the pupillary area and high IOP. The oncologist started local radiotherapy, and we continued our topical medications. Again, post-radiotherapy, the pseudohypopyon resolved. 2 months later, the child underwent stem cell transplantation from his brother. But again, 2 months following the stem cell transplantation, the child developed blurring of vision in right eye, and we could see amorphous whitish deposits in the vitreous of the right eye. Bone marrow transplantation was planned, and 4 days following the bone marrow transplantation, the child reviewed with us, and then he did not have either AC cells or vitreous exudates in either eye. But again, another month following the bone marrow transplantation, the child presented with left eye pseudohypopyon without any vitreous involvement, which was managed with topical steroids and continuing chemo. Again, another 2 weeks later, the child had blurring of vision in right eye with the recurrent vitreous exudates. Went ahead with the right eye vitreous biopsy and co-vitrectomy, which was again positive for blast cells. So in conjunction with the oncologist, the child was started on weekly intravitreal methotrexate injections, and post 4th injection, the child was symptomatically better, but the 5th one had to be postponed as the child's platelet count has fallen to below 20,000. But again, 2 weeks later, the child presented with left eye redness, pain, and blurred vision. The best correct visual acuity was 6/36 with an intraocular pressure of 40 mm of mercury. And the eye had corneal epithelial edema with 4+ cells in the AC, and mixed hyphema and pseudohypopyon, again with undulations on the iris. B scan showed minimal dot echoes, and bone marrow as well as peripheral smear again showed blast cells. So if you see the timeline, initially in September 2024, there was documented optic nerve head edema with blast cells in the bone marrow and CSF when reinduction of chemo was done. And Jan 2025, 3 months later, the right eye had pseudohypopyon and the chemo was stepped up. Next month, again rebound hypo in the right eye, and radiotherapy was added. And after that, stem cell transplantation, and following that, again in June 2025, there were right eye vitreous exudates. Bone marrow transplantation was done. Next month, the other eye developed pseudohypopyon. Chemo was continued. And again, August 25, there was recurrence of right eye vitreous exudates, which was positive for blast cells, and weekly intravitreal methotrexate was given. And again, in the next month, the other eye developed pseudohypopyon and hyphema, and the child was advised reinduction with chemo. The oncologist advised to restart chemotherapy, but the child's parents wanted to explore alternative medicine. So coming to the discussion, ALL is the most common leukemia in children, where there is proliferation of lymphoid blast cells which overtake the bone marrow and lead to decreased mature WBCs, RBCs, and platelets. Ocular involvement can be in the form of direct infiltration of the eye in orbit by neoplastic cells, vascular abnormalities affecting the retina, or neuroophthalmic impairment. Leukemic infiltration of the anterior segment is rare and usually portends relapses. The internal limiting membrane usually acts as a barrier to leukemic infiltration, but cells can enter the vitreous from optic disc. Most are B cell origin with CD19 and 22 positivity. T cell lineage, as in our case, is with CD3 positivity. Topical steroids, anti-glaucoma medications, and local irradiation, plus systemic chemotherapy for the underlying disease can help resolve iris infiltration, pseudohypopyon, and secondary glaucoma. So the take-home message is ocular relapse in ALL implies a poor prognosis and needs urgent treatment. It may masquerade as an inflammation or infection, and a high index of suspicion is needed for timely diagnosis and management. Thank you.
Very interesting case.
Thank you.
A very good presentation. I want to ask you one question.
Yes.
What would you have done differently in this case to have a better outcome for the child? Because the child was already on chemo, and then you had done a CSF as well, and then child was under your management. So
Yes.
what could we have done better, if at all?
He was already on chemo and underwent bone marrow transplantation. So all modalities of treatments had been given to the child, and
Okay.
guarded prognosis was also explained.
Okay.